hemolytic syndrome or whether the patient is a lupus nephritis. We do reach a diagnosis, so we need history, examination, and investigations. Unfortunately, our glass slides do not talk, and we cannot flip them around to tell us what's wrong with the patient. We count on you to tell us what is wrong with the patient. So we need a detailed, relevant history and examination, proper demographic data, basic lab evaluation, which will include everything: urine analysis, immunological studies, serology, and virology. Share the information you know. Add your clinical diagnosis. Tell us if you're doubting something which could be active. You need to mention previous pathological diagnosis. You need to consider double pathologies and underlying disease. You need to tell me whether the patient is hypertensive, whether he is diabetic, that he is not only presenting with acute renal failure. So the information needs to flow in both directions. When we come to look at the microscope, what we see is what we call a structural damage pattern. Considering that the kidney is really a highly complicated organ, the way it responds to injury and translates it into morphology is very limited. At the end of the day, we have only few morphological patterns which we see, and these translate to the hundreds of diseases which can affect the kidneys. What do we mean by this? We mean something like one disease can have many different patterns of renal involvement, as lupus nephritis, for example. And you can have one morphological pattern, like membranoproliferative glomerulonephritis, which could be a representation of different and diverse diseases. In order to be able to interpret this, you need someone who's experienced in renal pathologist, who knows quite good about clinical nephrology and have understanding of underlying pathological mechanisms. So back to our classification, this histopathology part actually are patterns established on light microscopy: membranous, membranoproliferative, focal segmental glomerulosclerosis. Please remember that these are patterns and are not diseases. What makes it a disease is the correlation between you and your pathologist. What are these patterns? In a simple way, just for simplicity, these patterns depend usually on the site of the deposits of the immune complexes. If you have subendothelial space, we can either in the subendothelial space, including the glomerular basement membrane, you can have them in the subepithelial compartment, or you can have what we call mesangial deposits. If you have deposits in the subendothelial space, this is what we call an endothelial pattern of injury. What will happen with this pattern of injury? You will have inflammation, you will have influx of phagocytes, proliferation, necrosis, maybe fibrinoid necrosis, plus or minus crescents, and this what presents an exudative proliferative glomerulonephritis, plus or minus fibrinoid necrosis and crescents. Where do we see this pattern? We see this pattern in all of this list. And these are different diseases: post-infectious GN, all the vasculitic syndrome, lupus, membranoproliferative glomerulonephritis, malignant hypertension, hemolytic uremic syndrome, and so on. This is just to show you what the proliferative glomerulonephritis. You can see there is hypercellularity in the glomerulus compared to the normal one I've just seen, and a lot of neutrophils. This is the subepithelial humps. This is post-infectious. Here, this is the basement membrane, endothelial cell, and deposits. This is a crescent. This is what we call a cellular crescent. You can see this is the glomerulus, which is collapsed, and this is the crescent. And this is another crescent, which is fibrocellular. The epithelial pattern of injury: this time you have no inflammation, but you have MAC formation and podocyte injury, which leads eventually to effacement of the podocytes. No inflammatory response. And this pattern of injury is seen in all of these diseases: membranous, minimal change, idiopathic FSGS, diabetic, amyloid, light chain, and so on, and in lupus, glomerulonephritis type 5. This is a glomerulus with just membrane thickening, diffuse basement membrane thickening. Notice here we have no proliferation, no neutrophils, nothing, and this is membranous GN. This is by immunofluorescence. These are IgG deposits. Again, this electron microscopy. This is a normal glomerulus, and this is what we call minimal change disease, or no change under light microscopy if we are not doing electron microscopy. And this is the effacement of the podocytes. instead of being separate and having gaps between each other, they are just one block. This is focal segmental glomerulosclerosis. This is an H&E stain, and you can see that only half of the glomerulus is affected. This is what we call a segmental pattern by sclerosis, total obliteration of the capillary loops, as you can see here. And this is a smaller affection with the trichrome or the fiber stains. And this is a membranoproliferative glomerulonephritis, and in this disease, you have both elements. You have the proliferation, as you can see here, and you have basement membrane thickening, more clear here in the PS, where you get this is what we call the tram track or the duplication of the basement membrane. These are IgM deposits by immunofluorescence and subendothelial deposits by electron microscopy. Finally, the mesangial pattern of injury, where you have the deposits in the mesangium, you get mesangial matrix expansion and cellular proliferation. Sometimes you can have crescents and bone capsule adhesions, and these are the diseases where you usually see this mesangial pattern of injury. So not every mesangial proliferative glomerulonephritis is an IgA nephropathy. This is what we mean by mesangial proliferative. You can see the basement membrane is relatively normal, and you can see this is only the mesangium expanded with all of these mesangial cells proliferation, no other cells, no endothelial cells, no neutrophils, nothing else proliferating. This is a case of IgA, and these are IgA mesangial deposits within the immunofluorescence. This is diabetic nodular sclerosis. These are what we call the atherosclerotic nodules, and this is amyloidosis. So you get the report, and when you get the report, you will find that the report should include the adequacy of the specimen, the size of the core, whether it's cortex or the medulla, and number of glomeruli. So you know where you are and how adequate your biopsy is. The report will include comments on the 4 compartments of the kidney, active versus chronic. Please remember that these compartments are not separate, and that usually your patients have multiple affections. When you read the report, do not focus on the diagnosis. Try to read the whole report, because sometimes more important than the diagnosis are the prognostic factors, and these prognostic factors, which would be supplied here, tubules, interstitium, blood vessels, arteries, and arterioles. Finally, with the renal biopsy, I know you take the biopsy and you want to know the answer. This is the solution, but you need to remember that with renal biopsy, we're only taking a snapshot on the time. We can catch the story very early in the beginning. We can be lucky and have it in the middle, and we can catch it at the end. Thank you very much.
Thank you, Dr. Wissam. We promise you in the next meeting, all of us will raise our hand.
I hope so.
After this lecture. Now we will move to Dr. Assam Nuruddin. His talk will be hypertensive, overhydrated patient, making sense of different strategies.
Bismillah ar-Rahman ar-Rahim. The title chosen for me in this pre-Congress workshop is about overhydrated hypertensive hemodialysis patient, making sense of different treatment strategies. In fact, when we are speaking about patients with hemodialysis hypertension, we have to know the characteristics of this bad type of hypertension, because it includes all of these. It is volume dependent. It is salt sensitive in the sense of each increase in the intake of sodium will result in much increase in the blood pressure. It is associated with this item of visit-to-visit blood pressure variability, which is associated with increased cardiovascular risk, mainly stroke. It is non-dipping, meaning that it doesn't go down at night, and this is also associated with increased cardiovascular morbidities and mortalities. And lastly, it is associated with what is called the lag phenomenon. And by the lag phenomenon, it means after even control of the patient's dry weight, there is a lag time between this achievement and the control of blood pressure, and this lag time may be sometimes weeks or months. One may ask, what behind all these characteristics of hemodialysis hypertension and the bad reputation of hemodialysis hypertension? In fact, the main cause for all these problems, as well as the main cause of hemodialysis hypertension, is simply salt. It is simply sodium and volume excess. This comes high on the list of causes of hemodialysis hypertension. So considering the issue of hypervolemia is very important in controlling this disease. As we know, when we take sodium will diffuse between the different cellular compartments, between the intracellular, the interstitial, and the intravascular compartment. And as we know, when you find sodium, you are going to find water. When sodium goes, water always follows. So if we have sodium here in the intravascular compartment, it will take water with it. It will result in hypervolemia and hypertension, the same in the interstitium and the same in the intracellular compartment. But there is another important aspect of sodium. We have to consider it. This is only one side of the coin. This is only called the osmotically active sodium molecules. And this will result, of course, in hypertension. But we have another non-osmotically active sodium. It enters inside the cells and it didn't go back. It continues inside the cells, resulting in several problems when we are speaking about hypertension. This osmotically inactive sodium storage inside the cells may result in hypertension by several mechanisms. For instance, if it is present inside the smooth muscle cells of the arteries, it will increase the calcium inside these smooth muscle cells, result in vasoconstriction and hypertension. There is a claim that this sodium, when shifted to the brain, may result in sympathetic stimulation, and this may be behind the increased sympathetic activity in patients with hemodialysis. So please think always in patients with hypervolemic hemodialysis hypertension about the salt, not only one side of the coin, which is the osmotically active form of sodium, but also about this important aspect, the non-osmotically active part of sodium that is remained inside the cell. When we are performing hemodialysis, the osmotically active part is removed by ultrafiltration. But the non-osmotically active part is removed by diffusion according to the concentration gradient of difference between the plasma and the dialysate sodium. And hence comes the great importance of this unusually not frequently used mode of managing hemodialysis hypertension, that is decreasing the dialysate sodium, as we are going to address these strategies very soon. So sodium overload doesn't mean only the osmotically active part that will result in rapidly on the shorter term by expanding the intravascular compartment with water in extracellular volume expansion and hypertension, but also it's the other face of the coin, which is osmotically inactive. On the longer term, it will result in vasoconstriction. And this may in part explain the lag phenomenon that occur in patients with hemodialysis-associated hypertension, even after control of the extracellular volume expansion. The blood pressure is not controlled after we remove much of this osmotically inactive sodium that results in hypertension by mechanisms not related to extracellular volume expansion. The strongest evidence supporting a role for the extracellular volume expansion derives from the observation that when excess body fluids are removed with slow dialysis, like what was done in the past 8 hours 3 times per week, and achieving the dry weight, the blood pressure is controlled in 90% of the patients, and most of these patients are not using antihypertensive medication. The only center all over the world who is still faithful to this principle till this moment is, as most of you know, Tassin Center in France. They are still using the same data of the old. They are giving long dialysis session, low dialysate, and they are advising their patient to limit their sodium intake, so they achieved more than 90% of their patients have controlled the blood pressure without using any antihypertensive medication, something not matched in any area in the world. The effect of hypervolemia is not only hypertension, as you see, it has a deleterious effect. The hypervolemia, all the body tissues in the brain